can you guys talk about that for a minute? The toxicities that you see with, especially with the combination in comparison to the single agent?
Yeah, so I think for PARP inhibitors, one of the biggest takeaways is really increased bone marrow suppression with anemia, cytopenias, neutropenia, thrombocytopenia as well. And so I think this becomes particularly relevant in patients that might have been more heavily pretreated with chemotherapies or have other significant bone marrow suppression. For example, we rarely see patients, but we do, that have bone marrow infiltration and cytopenias from that at the outset. So we really need to think carefully about whether patients have adequate bone marrow reserve to be able to tolerate the combination. Now, even though the studies, of course, did show that there are, as we would expect, more of those toxicities with the combination, we would perhaps hope that by using PARP inhibitors earlier in the castration-resistant setting, patients might have better bone marrow reserve than they might have otherwise had when we were using it later on in the course of castration-resistant disease.
Yeah, but I think the flip side is that when we're using it earlier, if we're going to be exposing patients to it longer, we're going to have to be watching out for some of the more dreaded potential toxicities, things like MDS or AML. There have been very few, if any, reports in the studies to date, but as we move them earlier and lengthier treatment courses, we need to continue vigilance on that. The other toxicity that I think has kind of jumped out a little bit from some of the studies is an increased risk of venous thromboembolic events. It's not enough that we need to thromboprophylax, but it is higher when we're using PARP inhibitors. And so we just have to maybe maintain a higher index of suspicion for someone calling in with a swollen leg or shortness of breath.
And what do you guys see as next steps for patients with HRR mutations? And do you think that we're going to get to a point where patients without HRR mutations are going to be receiving PARP inhibitors?
So I'll start out by saying we just need more data, especially in these HRR alterations that are infrequent. So as much as possible, looking for clinical trials or registering patients into databases is going to be critical to fill in our knowledge gaps. I'm not sure whether patients without any HR alterations will end up getting PARP inhibitors and benefiting from them. You know, there is this other mechanism of crosstalk with the androgen receptor that I think we just need more information about. So it's hoped that with ongoing studies, there will be some correlative science that can help us understand who are the other populations that can benefit, whether it be some of these rare HR alterations or in non-altered. You know, is there something that's happening with the AR and how it's evolving under treatment pressure that would support the synergy of these agents? And I think that's going to help us if we're looking to expand the population of patients who could benefit from PARP inhibitors.
Yeah, I completely agree. And to Dr. Dorff, your point, you know, it is provocative because a number of these trials, including PROPEL, right, you know, actually, you know, the overall analysis was in an unselected population, or even thinking about the arm that was recently presented and published for TALAPRO-2 with etablazolpidem and enzalutamide in the unselected population. There does seem to be some potential signal, but I think you're absolutely right that we need more data. And I think the other place that PARP inhibitors are certainly potentially coming to the fore are spaces like the metastatic hormone sensitive space. Certainly there's multiple neoadjuvant clinical trials. I think many people are trying to apply this class of medicines across the board as widely as possible. But I do think, to your earlier excellent point, Dr. Dorff, about long-term toxicities, longer exposures with you know, potential hematologic malignancies, that's not an insignificant consideration if somebody might get AML from having a PARP inhibitor for a long period of time. So I do think we need to be judicious about how we think about applying these drugs.
Well, I'd like to thank both of you guys for your time and your thoughts on how to interpret the recent data and the recent FDA approvals into our clinical practice. So thank you again for joining us tonight.